now.
And I want to say a hearty greeting to each and every one of you. I'm Dr. Brian Sims. I'm one of the senior medical advisors with the National Association of State Mental Health Programs. And I am thrilled to be a part of this discussion today. And I'm thrilled to host the episode 256 of the Crisis Jam. And today's Crisis Jam features a lot. So we're going to get to it as quickly as we possibly can. But today's topic, we're going to talk about the true cost of behavioral health care. We want to also take a look at where we're headed from there. Thank you. We're talking about also taking a look at crisisjam.com, a hugely information laden site. Go into it, log in, make sure that you're part of it, register, please, and start watching some of the live streams. If you want to take a look at some of the things that have been going on, you can also look at some things that have happened in the past, check out some of the debates that have occurred in the past, look at some of the other elements as far as lead stories and what kind of crisis news has been available. I mean, so jam-packed. We also want to talk about the YouTube connections as well, because in that you will find a lot of previous episodes that will let you know about various topics in the crisis realm. So if you missed any of them, it's a great opportunity to catch up with. Also want to take a look at AI in healthcare, because what we did during that time was take a look at what percentage of crisis jammers would be comfortable with their healthcare provider using AI tools. And we did a poll before, and it was interesting. We have the results of that poll, and it shows that from you all, 70% of you agreed and would be comfortable with healthcare providers using AI tools. So interesting perspective that I'm sure there'll be further investigations into and taking a look at what that really means going forward. And again, as we had mentioned during our run-of show, we're doing a sound check that just talks about our Crisis 4 features, because it will feature 4 live debates. But we're asking the question of you all, and you can place your answers in the chat box. What do you think we should debate next? And we'll just gather those particular elements as we go along. But I'm going to move ahead to the Crisis Hot Seat Q&A. And I'm just smiling from ear to ear because I have a very good friend, Laura Evans, who's going to be one of our persons who we're placing on the hot seat. And we're going to also have Errol Foster with us in this. But just to let you know, crisisjam.shop, if you are going to be a part of this and the jam, understand we got some swag for you. Okay, so Laura and Aaron, thank you so much for joining us. And let's just hop right on in. Laura, you're an old pro with this. Errol, you're an old pro. So we should be able to flow through this pretty quickly. So let's take a look at today's question. A new 2026 clinical study from Virginia Commonwealth University found that psychiatric inpatients benefited from daily what? And the choices that you have are A, therapy dog interactions, B, family visitations, C, mindfulness exercises, or D, extra pudding cups. So I don't know who would like to go first, or if you would like to poll the audience, because we're also letting them know that they can put a vote in. So I guess we'll go with the way my parents raised me. Laura, you have the first say.
Well, I'm feeling the heat. I'm feeling the heat. But as much as I love extra pudding cups, I am torn. And this is a recent study. So that makes me lean towards therapy dogs. I love dogs, but I think it might be, I'm torn between B and C. I'm leaning towards C because the audience is saying C in the chat. What do you think, Arrow?
I'm thinking the same way. New study, mindfulness we've known for a long time. I'm also hoping that the gift today, if we get it right, is extra pudding cups. So a lot going on in my head right now. But I think C is true also.
All righty. Well, I'm going to do this for you because you know how this question works out. We're going to throw a little clue at you to see whether or not it might help with this. The clue is the biggest impact was on loneliness. Does that keep you where you are, or are you looking at something else?
I'm going back to my therapy dog.
Yeah.
I mean, I'd rather a dog than family, but that might just be me.
I agree that family one can go either ways. I'm gonna go with therapy dog also. Are you
Wow.
gonna give us another clue or what?
Well, actually, I will tell you what the audience had said. At least theirs, well, the majority of them were going for mindfulness exercises. But again, they populated that before the clue came in. So it's a possibility that it may have changed after that. But I hear you both saying that you're going with now A. Is that correct? With therapy
Yes.
dog interactions?
Yes.
Great. Well, let's see what the answer is. And it is indeed therapy
Yay.
interactions. Great job, both of you. And to all those in the community that I have to say, we didn't give you that clue early enough, but sometimes the most powerful interventions in care isn't found in medication cabinets or treatment manuals. Sometimes it just simply shows up. Happy to see you. And, Laura, you had said it in the beginning about how that feeling just kind of hit you, because I think it paralleled with what was said in the chat box, that they thought it was one thing, but they were hoping it was another. So this is great. But understood. Thank you both for that.
For this, nom, nom, nom.
So we have to do our over and under where we cut the cookie. And Laura, you're so familiar with this, but we're going to give you both options on this one. Now, you just saw, or you may not have seen, the Join or Die documentary through Robert Putnam's, who's following up on the other book called Bowling Alone. Well, this is in reference to that. And in it, if you saw that little clip or documentary, he mentioned a percentage. Now, if you didn't see it, in that documentary, he says people who join just one community group are about what percentage less likely to die in the next year. So I will leave it to you as to who would like to put out the first figure and who would like to say either over or under that number.
Well, Errol, I was on the pre-show, so this, I think, is a shout out to join the pre-show so you could watch those clips. Unfortunately, I was chatting in the chat, so I missed the
number. Well, it's actually a good thing, Laura.
And I was meeting jumping, so I didn't get to see the pre-show. So we're just going to have to take a stab out of here, Laura. I think we can do it.
Yes. Okay. Do you want to take a number and I do over under, or do you want me to throw something
just
out?
One community group are bound.
I mean, the clip
I'm going to say it's over. I'm going to say it's just a little over 50.
So
I'm going to go higher. I feel like it's in the 70s.
Yeah. Okay. So we have one that says 50, and Laura, you're saying it's greater than 50.
I think so. I think it might be in the 70s.
A couple of populations in the chat box that suggest that it's a bit higher. Please feel free to throw other things into it. I see one that says a little less at 45%. Another one at 30%. But we're going to stick with what you had said. And the answer is indeed 50%.
Oh, spot on, Errol.
So, Errol, you did so wonderful. Congratulations.
Well, I mean, I had a 50-50 chance. So, Brian, I can't claim a lot of skill there.
But you had to have a starting spot. You decided to start with 50%. That is great. Look, thank you both. Thank you so much for just participating in this. Laura, I'm going to have to get together with you later on because I'm going to have to borrow one of your t-shirts because you got so many of them going for you now. Pretty sure it's there. But we're now going to move into our breaking news. And here's what I'm going to do. I'm going to post the breaking news by handing it to Dr. Matthew Goldman. And Dr. Goldman, if you're there, come on. I'm going to hand it to you and not say anything else other than that. Go for it, sir.
Well, thank you. It is my pleasure for this episode of the 256th episode of the Crisis Jam, to share that the breaking news is that we have a new inductee to the Four Timers Club, which is Dr. Margie Balfour. Margie is a hero in the crisis space. I am lucky to call Margie a friend and a collaborator and a mentor. I have learned so much of what I know from Margie. And as we are about to run through, Margie is incredibly generous with her knowledge and her expertise and has shared so much here at the Jam. So she is one of the 10 folks who have done a have been a feature presentation, done a feature presentation 4 times. The first was way back in season 1, the 21st of all Crisis Jam episodes, when she presented on the crisis workforce shortages and solutions. Her next featured presentation was over 100 episodes later. She did one on the evolution of a comprehensive crisis system. And then I believe her third was a debate that she did with another friend and leader in the field, Travis Atkinson, where they debated about crisis facilities and receiving involuntary versus voluntary referrals. And then today she'll be presenting on the true cost of behavioral health with Matt Miller. And so, but that's not all. Margie has also led a lot of more creative and interesting activities here in the Jam. One thing I admire about Margie is her presentations and her slides are the best. She makes such interesting and dynamic and fun and creative presentations. And she shared that with us here in the Jam with a variety of creative memes. This is all fun throwback, lots of Game of Thrones references, which I never watched, but she loves. And I think I got the gist. And so this was always so fun sharing these memes with us. And I think with all of the featured presentations and everything, oh, right. And then, yes, she is also a big fan of Noah Wiley and The Pit. And that's what it was. She does lots of back of the envelope math. So sort of like, how much would this or that compute to if we did like a really rough pro forma, sharing that kind of thinking with us, which is so important in the crisis space as well. So she's really shared sort of that whole approach to thinking, which I think we'll see some of in today's featured presentation as well. So with that all rolls up between the 4 featured presentations. She's also done 6 roundtables, 4 trivia, 2 data corners with me, 2 breaking newses, and then the 10 crisis memes. She has appeared 28 times on the Crisis Jam, which if you do the math, that is more than 10% of all Crisis Jam episodes that have ever happened, Margie has been a part of. And so it is my great privilege to induct and welcome Margie into the Crisis Jam 4-Timers Club. And I think with that, I'll turn it over to you, Margie, if you have any comments you want to make.
Well, thanks, Matt. That was as good as Ryan Gosling doing the induction. So yeah, and David had asked me to guess how many times. I guess he gave me like an over under of how many times I'd been on the Jam, and I'd forgotten about the memes. So I'm always, I love this group, and I'm always, happy to come on here and talk about crisis work. So thanks.
Awesome. Well, thank you, Margie. And with that, we're going to transition right into your featured presentation. Oh yeah, there's her applause. And so joining you now is Matt Miller, who is at Connections Health Solutions and is the Chief Growth Officer. I'll just say briefly, we're very lucky here in King County, where I work, to have Connections as a partner in implementing crisis services. And so it is a pleasure to introduce you both and hear your featured presentation.
Thanks, Dr. Goldman. It's always difficult to talk before or after Margie. So I'm going to just kind of tee this up. So just by way of introduction, Connections currently operates crisis stabilization centers and mobile crisis services in 5 states, with 6 centers operating today. By the end of this year, we'll increase that number to 9 centers in 6 states and are anticipating at least an additional 4 centers in 2027. So there's a lot of momentum in the crisis stabilization facility space. Last year, we published a report looking at the true cost of behavioral health services with and without an effective crisis stabilization system. So the report examines the costs of relying on hospitals and relying on the criminal justice system and behavioral health crisis care, looking at the monetary expenses, as well as looking at the sometimes overlooked human toll. So during today's presentation, we'll cover a few of the key highlights from that report. Let me start by saying the crisis system isn't broken. It's not broken because it hasn't been fully developed yet. An effective system isn't a replacement for the existing behavioral health services, but it does bolster and enhance the current system in a cost-effective manner, and we believe produces better outcomes. As we all know, we're seeing significant momentum and opportunities to build effective behavioral health crisis systems and crisis facilities that bring innovation to a healthcare space. And most importantly, specifically address accessibility, quality, and better outcomes, both for the individual and overall healthcare savings. Before getting to the solutions and turning to Margie to go through some of the outcomes of the study, I'd just like to spend a couple minutes on what actually is broken. In most cities, counties, and states throughout the country, our response to behavioral crisis care are misaligned with the community needs, and definitely misaligned with individual needs. Our system is historically reliant on emergency departments, typically not well equipped to treat a behavioral health crisis, and jail or detention centers, which are also not equipped to treat that crisis. So on to the slide. So 18 hours, that's the average wait time across the country that an individual in a behavioral health crisis waits. They're boarding in an emergency department, waiting to see a provider, waiting on an inpatient bed, or waiting for any type of treatment. This wait time typically exacerbates the individual's crisis, leading to longer and more costlier care. $2,700 is the average cost of an individual going to an emergency department. That includes typical costs and charges of the ED admission, the cost of emergency department staff and referral services. But what it doesn't include is the cost of law enforcement and other first responders' time into the ED to ensure the safety of the patient and or the emergency department staff. Certainly worth pointing out as well, 56% of all healthcare costs are attributed to individuals with behavioral health conditions, with the most costly behavioral health services, that of the ED and long-term inpatient hospital, being able to be addressed more effectively with a system that actually works with an effective crisis system. Go to the next slide, please. So without an effective crisis response system, we're increasing not only overall healthcare costs, but the individual costs. On the human side first, we're not providing the appropriate services to individuals that are in need. There's not a trusted place to go, which oftentimes results in addressing the crisis in real time, leading to larger behavioral health complications. And we all know that being incarcerated for behavioral health issue isn't treating the issue at all. The financial strain on the system continues to grow. I talked about the ED admission. An ED admission followed by an inpatient hospital admission on average throughout the country is anywhere between $12,000 and $15,000 per episode. That same encounter with an effective crisis system and a stabilization facility ends up being a fraction of that cost. Next slide, please. So because of the historical lack of community and state investment, there's been an over-reliance on grant and lack of long-term financial sustainability. We've turned our jails into the largest centers for mental health care, which is not effective, obviously. And we have a cyclical process that produces inferior outcomes. As we know, and what the JAM has been focused on throughout is there are alternatives. There are better ways. And with that, I'll turn it over to Dr. Margie Balfour to run through the next.
Thanks. And many of you may have seen this slide before, and it is one of, I think it's my most favorite graphic that I've ever made, because it really illustrates those principles that Matt was talking about for the solution. Because all of our crisis services, if you align them towards this common goal of getting care in the least restrictive setting, which is our clinical goal. So our goal, if you come from a clinical standpoint or from a social justice standpoint, but it also very closely aligns with what our financial goals should be when you're talking about responsible stewardship of taxpayer funds, because those least restrictive crisis services are also least costly. So, so you've got a coordinated system where you've got your 988 and your mobile crisis teams and facilities and, other crisis residential and post-crisis wraparound all working together. With easy access for law enforcement and 911 and the justice system to divert people into care. And all of the decisions about how all of that is organized have this collective impact on those common goals of reducing jail and ER and hospital. Next slide. And the kind of most complex component of the crisis system and the most costly to set up are crisis facilities. And for a long time it's been kind of a mess where you say the word crisis stabilization unit to 10 different people in 10 different states and you get 15 different answers on what that looks like. And and that's one of the reasons when you talk to payers, private payers who aren't paying right now for crisis services, that's part of what they say the challenge is we haven't even defined what these services are. So how are we supposed to price it and pay for it and reimburse for it? So SAMHSA, with the work of a lot of people who joined the Crisis Jam, were I think part of that process, came out with the first ever federal model definitions and standards for all the different crisis services. And so if you're a private payer, here are your definitions. But and in a crisis system, ideally, you want a really broad continuum with all these different levels of care, so that you can really, fit the person's need to what, the level of care is. Kind of how, in a system, for emergency medicine, you plan your system or with level 1, 2, 3 trauma centers so that you have an organized way where, people can get the care that they need. So we're starting to build that framework for crisis services. Next slide. And when you're talking about having the biggest impact on cost, on the things that Matt was talking about, it's really those high intensity, high acuity crisis centers that, is what a community really needs to start to make a dent in that. Again, all of the levels of care. And if they were talking about the debate that I did with Travis, where we talked about how it is important to have all the different levels of care. But when you're talking about the people that impact the costs that Matt was talking about, people who end up in jail or people who end up involuntary in ERs, restrained, and then they assault staff because they're untreated and then they get taken to jail. All of that, those are the people that, if you don't have a facility that can take them, that's where they're going to end up, is jail in the emergency department. So that high intensity emergency behavioral health center or the hospital based, more like an empath unit, also fits in that category. Those are the facilities where you've got specialized treatment, you've got specialized staff, where you can really work to get people the care they need. And most of the time, you can often help people stabilize so that they can then go on into community-based care. Next slide. And these crisis services and the different types of facility-based services, they're not like monoliths. They're more like Lego blocks where you can have a facility that has multiple levels of care so that when the person arrives, so this is what we kind of our model that we've evolved at Connections, where people arrive however they arrive, walk in, ER transfer, first responders, police, but more increasingly EMS now too. And then we're kind of like a sorting hat where you've got things like urgent care, or bridge clinic for that someone to follow up, component, for the lower acuity folks. And then you've got, for your high intensity people, the emergency care, which is the 23-hour OBS for less than 24 hours, the extended stabilization for those who need to stay longer. And then as a result, people who come in, most are able to, get what they need, be discharged. Your involuntary folks are, even if they do need to go on to, inpatient care, many of them can be converted to voluntary, so they're more engaged in their care and still have a good experience. Next slide. But then how do you pay, for all of this? So, that's always the big question. And, the purpose of this slide is not to go over all of the details in the tiny type, but you can see as Connections has been expanding into different states, like Matt said, this is a system, or this is a whole field really that's still in development. And the regulatory mechanisms and the payment mechanisms don't exist, or they're not very mature in most states because, if you're building crisis centers right now, you're kind of pioneering this and working with the states in partnership. But this sort of two main principles that this illustrates is that if you want to serve everyone, then you have to go out and get the money for everyone. And so that means braiding funding together. And in some states like Arizona, and Washington, especially, if you look at King County, I think legislation has been passed to make the rest of the state actually look more like King County. But, in some places you've had, the state or the county braids that funding for you. So then you as the provider sort of receive a braided funding source. In other places, that hasn't been done yet. And so then as the crisis provider, if you want to, be doing this work in a sustainable way, then you kind of have to go out and braid it via multiple contracts with different people, then different entities. Um, but then, for those of you who've read the new SAMHSA guidelines or the roadmap report before that, another key feature of having a well-coordinated, organized system is that idea of an accountable entity that's sort of overseeing and, the planning and the flow and all of that. And you can see that in some places the funding kind of supports that. So, in Arizona and Washington, King County, it's pretty obvious who your quote accountable entity is because of how the funding flows. So, as states are figuring out how to fund this, that's something to think about too when you think about how the money flows, because it's a little less clear because you may have multiple masters if you as a provider are braiding that funding yourself. And then again, just to point out that what's missing in most of these is private insurance. Although some states have started to pass, legislation that requires private insurance to pay for crisis services, which I hope becomes more common. And then we've been working with many people on this call on a bill at the federal level to have a Medicare demonstration to finally have Medicare pay for some of these services. Next slide. So then, what about impact on cost? So, Arizona, as people know, have been investing in crisis services for decades now. So it's a mature system where you can start to look at some of these impacts. These numbers are actually done by the Crisis Now folks, way back in 2018. And it's kind of back of the napkin-y, looking at sort of extrapolating from different studies, some of the stats that Matt mentioned before, and kind of trying to get an estimate of what is the impact. And you see a lot of impact in avoided inpatient costs, a lot of impact in terms of reduced psychiatric boarding, and then also in addition to just looking at dollar amounts, when you're talking about the impact on law enforcement, converting that, I think it's very clever how they converted that to FTEs of officers, because all law enforcement agencies are understaffed, and that's a very powerful argument when you're trying to get cities and municipalities to buy in and invest in crisis services. Next slide. Down in Tucson, Tucson police looked into some of their impacts in a little more detail. So a lot of the things that is driving law enforcement time and cost are, what are called nuisance calls. And so as the crisis system has developed, those have gone down. Also, a culture change in how they respond to certain incidents. And you're seeing this happen nationwide as crisis services get developed. But one, I think, really striking impact is no longer calling the SWAT team automatically for people who are suicidal and in their house, and instead, working with crisis system. And that's a huge impact. I mean, each one of those is $15,000. So again, these are really powerful arguments that you can make when you're trying to advocate for investment and collaboration in crisis care. Next slide. And then more recently, we've tried to do a more formal research analysis of the system in Arizona. So this is down in that first slide was Maricopa County, and then this is down in Pima County. Although we did a similar analysis for Maricopa, where we took Medicaid claims. Arizona's one benefit of the way the crisis system works there is that everyone is entitled to crisis services, regardless of your payer. So everyone is in that Medicaid claim set for that first 24 hours at least. And so we were able, and Dr. Goldman was a collaborator on this project as well. And we were able to construct episodes of how people flow through the crisis system. We didn't have phones, but we started with mobile or crisis facility or the emergency room or hospitals, and looked at how they flow through that episode. And but the kind of the take-home message is, if a crisis system exists, people will use it. So, 57% of those crisis episodes began in a crisis level of care, so mobile or come into one of the facilities rather than the emergency room or inpatient. And then if you look at how they flow through the system, most of those, so nearly 70%, remained in the crisis system, so not going to the ER or inpatient. And then for those that went through our facility, where we had in Tucson, the Crisis Response Center, where we had the electronic health records that we could merge with those the Medicaid claims, we looked to see who had reutilization in the following month. And most people, so that's the purple there, did not reutilize any crisis services. And of those that did, which I thought this was a really cool finding, is that if they did reutilize, over 70% of them had that reutilization in a crisis setting. So with the mobile team or going to a crisis facility rather than the ER or inpatient, which is good because sometimes we get into this binary of like all reutilization is bad. But we're also telling people, if you have any more problems, reach back out to us and ask for help. And, so they are, which I think is good. Next slide. And then we also looked at the involuntary population. And for those 60% of them, we were able to convert over to voluntary care. And then both of those groups we looked to see what clinical factors were associated with being more or less likely to reutilize in those 30 days. And so both of those involuntary folks were less likely to reutilize. Also, some clinical factors, ones that you might expect, being homeless, stimulant use, a lot of meth in Arizona, psychosis. And so this kind of research helps us then, so these are going to be the highest cost folks, the ones who do reutilize. And so, gives us some guidance of where we maybe need to target some more specialized services. And we're currently doing a study follow-up to try to put cost to this data, and hope to continue doing these kinds of studies with our new center in Pennsylvania. We're hoping to do like a pre-post study there. Next slide. And then, we're seeing similar trends in our other centers. So this is really preliminary data. So, don't take it as like gospel truth, but, we Dr. Goldman mentioned that we, have a center up there and we've been working together. So this is what King County did with the data that our center there sends in a data feed, where you see similar flow, where most people are getting their crisis resolved in these, you have these with all under one roof. You've got urgent care, you've got the observation unit, you've got extended stabilization, and you can see how we're trying to, whenever possible, get that crisis resolved in that least restrictive, least costly setting. With that, I'll hand it over to Matt, who will talk more about our work in King County.
I'm going to go really quick here, just a little bit of a case example of, getting from here to there. Prior to levy being passed in King County, we had the opportunity to work with, local champions in King County, in North King County. 5 cities came together to say, we want this solution, we want this crisis center. And we partnered together with the county, with the Department of Commerce, with the state for capital funds and the development of that program to implement a full crisis center. We're happy that Kirkland Center is now one of the 5 CCC programs in King County, and look forward to continuing to work with the state and the county there. Next slide, please. So I had mentioned earlier, significant momentum, especially in the last couple of years. Growth in the crisis space, largely, driven by 988 and the implementation of 988. Increasing mobile crisis providers and continuing to increase crisis stabilization facilities, all which contribute to ultimately better costs and better outcomes at a system level. Just a quick snapshot here, the things that we've seen and we've all seen really in the last couple of years, changes to licensure, changes to billing codes, the ability to dispense meds and use of seclusion and restraint as a last result. The ability to take involuntary and voluntary individuals, really be that true no wrong door, is contributing to the success of the growth of crisis centers throughout the country. And finally, so just some, how we view about continuing the momentum. Communities look to continue to invest in the 3 pillars of the stool of 988, someone to respond with mobile and a crisis stabilization facility. Build those local regional partnerships with hospital emergency rooms, with the existing behavioral health delivery system and law enforcement. Explore public-private partnerships to ensure the sustainability of programs. Continue to maximize the reimbursement and revenue that's coming from insurers. And finally, promote policy locally and at the state level. Zoning, getting the right type of building to have a stabilization stabilization facility, and to remove barriers to access. I think we're at the end here. The full report is available. You can use this email, hello@connections.com, or go to our website and be able to download the full behavioral health true cost report. So thank you.
Certainly want to thank both of you. Dr. Balfour, congratulations, number one, but also thank you, and thank you, Matt, for what is also showing in the chat box as a lot of positive response in terms of your data. So we're going to make that available to them clearly, but thank you both for that presentation. We're going to quickly move over to the roundtable, and we have with us Phil Evans, who's the CEO and President of Protocol Services. And Phil, I'm going to let you take it from here. Just some comments on this presentation.
Thanks so much, and Margie and Matt, thank you. Super exciting to see what you're doing with the data here, and I echo the comments in the chat in that regard. Protocol's been working on this issue of what are the true costs of doing what we do for about 30 years now, and we're at the very front end of this continuum. For folks who don't know, we run crisis lines. We have about 500 different programs that we operate across the country. The larger ones are New Mexico's 988. We're a part of 988 in New Hampshire. We're a national backup center for 988, and we've just launched in Region 5 of Virginia for 988. And this question of how we staff has always been, and the cost of that staffing has always been front and center for us, particularly this issue that we talk about in terms of the firehouse model. And I see that as common through all of the pillars, right? The conversation with funders about what it takes, how much time you have to spend just available, or really just sitting and waiting for that next call, or that next mobile response, or that next person that needs that bed. Tremendous amount of infrastructure and time dedicated to that. And in our environment, that's as much as 35-40% at times of what our staff are doing. If we're going to have a 20-second, 15-second average speed of answer, it really takes that amount of availability. And it took us the first 5 or 8 years of running this business to really figure that part out. Like, oh, we were missing a large portion of that component. And so what you guys are doing, which is so fascinating, with the Sankey diagrams, and mapping that flow is really, I think, so important in continuing to make this case all along this continuum for the value and basically the return on the investment, which for most of my career has been philosophical, theoretical, but not scientific. And what the work that you're doing is really bringing so much more science into this equation. If we invest up front, here's what we can expect in return. And I love the Sankey diagrams that you put together. And I'll just comment and then open it up. We've just launched in Virginia, Region 5. And in the first, we have one full month, but in the first 10 days or 2 weeks, what our stakeholder there told us is that we were able to provide to them through the 988 line, in 2 weeks, we provided the number of care navigation referrals to their community mental health staff that they had received in the entire prior year. And so I'd love to pay attention to that and do a case study and chat with you about what that could look, 3 months, 6 months down the road, because there's that interstitial value between the pillars that I think could tell such a powerful story. And maybe David can come up with an architectural term that will add to the three pillars and what do we call the connections in between. Anyways, thank you so much.
Well, thank you, Phil, for your wonderful comments and very encouraging, sir. Thank you so much. We're going to move now to the briefing room, and we have with us Justin Pallison. And Justin, some comments from our SAMHSA.
Absolutely. Great to be here. Just 3 announcements, really. The first one is that the Notice of Funding Opportunity, or NOFO, for the Cooperative Agreement for the 988 Suicide and Crisis Lifeline Administrator has closed. The last day of applications for that, I believe, was Friday, February 27th. So, of course, we look forward to the outcome of that. Speaking of NOFOs, we encourage everyone to pay attention to the fiscal year 2026 Notice of Funding Opportunity Forecast. That can be found on the SAMHSA website. And we highly encourage you to subscribe to the grant funding announcement emails. And you can find the button to subscribe to those announcements on the SAMHSA grants dashboard. Finally, we recently released the Model Standards for Crisis Care Workers resource. So this new SAMHSA advisory introduces these, national model standards for crisis care workers, and the goal is to help states and communities build a skilled, consistent, and accessible crisis workforce. I heard you all mention workforce issues earlier in the call, and I'm sure that is an ongoing challenge for many of us. And we certainly encourage you to check out this resource and disseminate it among your networks. I believe this resource is planting some very interesting seeds, and I look forward to seeing how those seeds grow in the coming years. And that's it from your federal partners.
Well, thank you so much, Justin, for that information. And thanks as always for the wonderful work that SAMHSA is doing. We appreciate it tremendously. And we want to move now to the next portion of our briefing room through our own Nashville representative, Christy Malik. And Christy.
Great, thanks, Brian. And I also want to echo Brian's comments, Justin and the SAMHSA team. Thank you so much. The advisory is just a beautifully written report, and I think the framework really further supports that no wrong door crisis system approach that really can help serve all populations. So again, just thank you so much to the SAMHSA team for this incredible report. I just quickly want to touch base since many states are in their legislative sessions right now. We just wanted to highlight a Nashville resource, and that is our 988 fee FAQs document. We hope that crisis jammers find this resource helpful as states and jurisdictions try to identify sustainable 988 funding, such as the 988 fee. I do also want to point out regarding the 988 fee, some of the questions, I think many people, advocates and educators in the field get, well, what's the oversight of 988 fees? And I did want to bring to you all's attention that the FCC did release their 4th annual 988 fee accountability report, which was submitted to Congress in November of last year. And it outlines how 9 states, and those 9 states are California, Colorado, Delaware, Maryland, Minnesota, Nevada, Oregon, Virginia, and Washington, on how they collected and distributed their 988 fees in calendar year 2024. So my colleague is going to drop the link in the chat if you would like to take a look at the FCC 4th annual report. So, and on that note, that's all we have here with Nashville. So again, great crisis jam. And Brian, I'll turn it back over to you.
Christy, thanks so much, and thanks for all you do in that realm with 988 and explaining it in such a way that we can all know exactly what direction we're heading in. So thank you for all that you do. And we're going to move now to our data corner. And in our data corner today, we have we're going to bring back Dr. Matthew Goldman, who's going to interview NYU's Dr. Jonathan Pirtle. So Matt, go right ahead, sir.
Fantastic. Thank you. Jonathan, are you with us?
Yeah, I'm here.
Awesome. Thank you for making it. My distinct pleasure today to get to bring Data Corner back. It's been a while since we've done Data Corner. This is a segment where we like to highlight recent research and evaluation and data-related activities that are happening in the field. And Jonathan Pirtle is associate professor at NYU and is a real leader in crisis services research. And since the feature presentation today was about cost of care in crisis services, I thought Jonathan would be a great Data Corner guest to hear about some of his research on the cost of crisis services and the cost of the 988 line. So have a few questions for you. We're going to do this in interview format, which is a little different from our research presentations we've done previously. And so Jonathan, welcome. Would love to hear from you. If you could tell us a little more about your research project that you're currently working on related to models of financing in crisis care.
Yeah, totally. Thank you, Dr. Goldman, and thank you for having me. Always great to be on the Jam. I swear I own more than one sweater. That picture may contradict that, but I swear I own more than one. So I'm very fortunate to be leading with a great team, a 5-year R01 funded by the National Institute of Mental Health, really focused on evaluating different state financing approaches for 988 and crisis care. So the impetus for this project, really being, 988 is a federal initiative, but states are so critical when it comes to sustainable financing, and I would argue probably the ultimate success of 988. So our research project has 3 aims. As I may have mentioned, we're in year 4 of the project, just starting now. Aim 1, we're complementing some other efforts out there, creating this longitudinal data set, trying to calculate with as much precision as possible how much money and how money is being spent in every state for 988 and crisis. In aim 2, we did a big survey of about 400 crisis professionals last summer. Some of you may have been bothered by me to complete that survey, followed up by a bunch of qualitative interviews to really kind of explore and unpack how things have been going when it comes to financing. And then the third aim, which is arguably the most important aim, which we're really starting to get enough data to do now, we're using difference in differences designs, which is a quasi-experimental approach, to really try to tease out the effects of different state financing approaches on outcomes we care about. So things like wait times, in-state answer rates, emergency department use for mental health crises and self-harm, and also suicide death rates.
Fantastic. We have so much to learn from what you're working on. Is there anything you can share us about what you've learned so far?
Yeah, so I'll highlight a few things from these different aims. So just in terms of this survey, we asked folks about a number of different things about kind of how it's been going with financing. Is there enough financing? Where do you see the biggest pain points around financing? Not surprisingly, here we were stating the obvious, but we have data to support the obvious. Funding has been a real challenge. One finding that comes to mind, only, I believe, about 10% of respondents said there was sufficient funding for them in their state to meet demand for 988 and crisis care. From their perspectives, issues related to staffing, being able to pay people enough to do this really hard work, to recruit and retain high quality staff, being a big challenge. We did interviews last summer, over the last year really, with 40 crisis professionals in states that had adopted 988 telecom fees. So this is the places where the fees had been adopted. They'd been on the books for a while. We wanted to know how that was going. Not surprisingly, respondents said the fees were really great. By and large, it was a meaningful amount of money. They were extremely helpful. The funding source was perceived as sustainable, right? So these fees are passed by the state legislature. It's a little bit more stable than budget allocations that are year to year, perceived as being flexible in most of the states that allowed them to meet emergent needs related to 988. But then some challenges were brought up as well. Respondents said, it was a substantial amount of money, but it often still wasn't enough money, especially when it came to like real investments in infrastructure, like IT infrastructure and things like that. And there were also some concerns that were brought up in a small number of states, but I think potentially meaningful, the fee being perceived as enough money that kind of healthcare companies, for lack of a better term, who weren't traditionally interested in crisis were getting in crisis. And some call centers that were really volunteer driven, nonprofits kind of getting brought into this more, for lack of a better term, big healthcare space, and concerns about what that means for the culture of crisis care and making sure that the good stuff isn't lost in that transition. And lastly, I'll say we're wrapping up analysis now. We analyzed all state final enacted budgets from 2021 through 2026, trying to quantify all money earmarked for crisis services and suicide prevention. Long story short, we see an increase across the board. When we look at the national average, we see those increases being larger in states that are in the Northeast and in the West. And when we just do a simple bivariate comparison, we say, states that have adopted a 988 telecom fee, are they earmarking more money for crisis and suicide prevention? The answer is unequivocally yes, about twice as much money is what we're finding on average.
Wow, great information. What are the challenges of studying crisis? I'm often beating the drum here of we need to do more crisis research. It's so hard to fund this work. There's so many questions they have to answer. So what have you found?
So in the financing bit, it's extremely complicated. So as I'm sure most of you know, and I'm sure it was probably brought up earlier in this call, it's all so complex, right? So when we wrote this grant, we told this clean story of we're going to evaluate, what happens when a state adopts a 988 telecom fee, right? The yes, no thing. Obviously, it's way more complicated than that. States vary in their fee structure, their oversight, how long it takes for that money to come in and then be spent out. States vary in terms of how they report out their spending, right? So for some states, we can see line items. Okay, the money is going here, 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 and here. This for call centers, this for mobile crisis. In other states, it's not as clear, and we're really not sure. So that different reporting kind of problems on the independent variable side of things, and then the dependent variable, right? So things like 988, wait times, call abandonment rates. We've gotten data from Vibrant at the state month level over time to evaluate that. And the data, it turns out, they're really, really noisy. For a lot of states, there's a lot of variability between months, and we're not sure what's driving that, but it makes it hard to model kind of the counterfactual. What would have outcomes look like in a state that did adopt a telecom fee if they didn't, right? That's kind of the question that we're asking. So those are just some of the challenges. And of course, the time lags, suicide death data, for example, we are just about to get, 2024 data. It takes a while to get the level of data that we need to do these analyses.
Yeah. Thank you, Jonathan. It's great to see you. Appreciate your joining and sharing.
Yeah, thank you for having me.
I'd like to echo, thank you, Jonathan, for coming, and Dr. Goldman, as always, for providing that commentary for us. We now want to move to the Voices in Care, Crisis Care, and we have with us today Johnny Crowder. So, Johnny, if you're available and ready to come on, go right ahead.
Yeah, thank you so much. It's my first time hearing the phrase crisis jammers, and it reminds me of Kool-Aid jammers. I'm sure I'm not the first person to say that, but it makes me smile. Thank you guys a ton for even caring. I will tell you firsthand, I grew up really struggling with suicidal ideation, and I was so convinced that nobody in the entire world gave a crap about what I was going through. So the fact that there are 177 people on this call right now caring about people like me, well, I simply wouldn't believe it. So just thank you guys for caring. It means the world to me. I missed part of this call, but I will tell you just from my firsthand lived experience, hearing people talk about this part makes me glad that I do my part because I don't want to do y'all's part. It sounds really complex. But I'll give you like 30 seconds of context so you know who I am, and then I'll tell you a little bit about my experiences in the system of care. I'm Johnny. Nice to meet you. Right now I run a mental health company called Cope Notes, and we provide preventative support to youth and adults all over the world. So I'm big on prevention, and I'm a mental health advocate. So I speak maybe 50 or 60 times a year at conferences, events, fundraisers, all sorts of places about my lived experience. And the reason why I'm so passionate about lived experience and passionate about prevention is because, as you could probably surmise, I grew up with severe mental illness. And I will tell you that growing up with severe mental illness, in a low income household, like when you guys are talking about fees from the high level, like, well, wait, who's paying like the telecom prices? I will tell you that as a teen who is struggling with suicidal ideation in a low income household, I didn't give a crap about any of that stuff. All I was thinking was like, how do I get support immediately? And I'm really grateful that you guys are solving these really large scale funding problems, because I will tell you I went to school for psychology, but I was really interested in consumer psychology. And I was interested in like how and why people make purchasing decisions. And I will tell you that if I had to pay 1 penny to engage with crisis care, I wouldn't have. That would have been just enough of a hurdle for me to go like, you know what? Maybe it's not that serious. So like, even if I had to put in my credit card information, it said it's a free trial, it's $0, we just need your credit card, I'd be like, nope, because there was some part of me that would have kept me out of care for whatever reason. It was like, I tell people I could always find a reason not to go to therapy. Like, oh, my goldfish has homework or something. I could always like cook something up so that I wouldn't have to deal with it face to face. And I'll just tell you, like, part of the reason why I'm so passionate about prevention is because I'm fortunate to have survived suicide. And I know that many people are not in that same situation. And I always think like, what would have happened the day before my first attempt if I got some kind of preventative care, or a week before, a month before, or a year before, or what if in that moment where I was very, very close to taking an action like that, I was aware that there was a resource that I could reach out to that was completely anonymous, completely free, wouldn't report me to my parents. I was really afraid of them finding out what I was going through, or report me to the police or to my school. I basically was, I wasn't aware that things like this existed, at least back then. I don't know if they did, but I'm the main reason I am here. I'm only here for a couple of days or for a couple minutes. I'm here for a long time. I'm here on the planet for many more days, but I'm here on the call for just another minute. And I just want to share, like, I totally appreciate the time and effort you spend solving these big macro problems, but please do not forget who benefits from that. When you're like pulling your hair out and you're like, this is defunded and I don't know who's going to pay for this and all the paperwork and contracting, I completely empathize with that. But please don't forget, there is like a very afraid teenager who is so confused about what's going on and has no idea where to turn. And you guys solving these problems helps kids like me all over the place. So thank you for doing the work, because it makes a huge difference.
You are amazing. That's all I can say. You are amazing. And it is so good to hear that. And I think if you've been monitoring the chat box, you see that they're right on board with every thought that you had and every expression that you had. But thank you for doing what you're doing, because it does make it. I think I saw some comments about what you comment on is being bolstered in terms of why we do what we do. We do it because of the people that we serve. So thank you so much for that. And I'm going to move now to hand it over to Kristen Ellis, who's going to take us out. And before Kristen goes in, Dave Covington put a beautiful comment in the chat box, and I just wanted to bring everyone's awareness. He put in there that crisis volume doesn't flow like a predictable stream. It comes in waves. So we can kind of carry that out with us. Kristen, you go ahead.
Well, how do I follow any of that? But before we go on, I just a huge thank you, Johnny. My goodness, we may want to have you on as a feature. I'm just throwing it out there. And a big thank you to Dr. Margie Balfour and Matt Miller for today's conversation about the true cost of behavioral health care from that high level view, and then also how Johnny brought it home on remember the people that we're serving. Really looks to look past buzzwords and what sustainability really requires. Thanks so much, Margie, again, for your 4th featured presentation and your induction into the Crisis Jam 4-Timers Club. Today's, by the way, if you didn't catch it in the chat, we did put some giveaways. Today's 4 winners are Justin Volpe, Howard Trachtman, Jane Gabriel, and Day Catalano. You'll be receiving a code to our crisisjam.shop. But before we move on to what's coming up in the next few weeks, this quote on the screen, probably one of our favorite moments besides Johnny and hearing about how we pay for stuff today, was our trivia question about therapy dogs. It's a huge reminder of how important connection is even from our furriest of friends. I don't know about you. In crisis care, sometimes it's not just about systems and policies. It's about presence, warmth, human connection, and sometimes our animals. All right, let's move on to Crisis Now 4 is coming to Washington, D.C. in July, and the agenda is now live on the website. I promised you it would come. I wanted it before the end of February, but it's there now. Be sure to check it out. Registrations are strong. Momentum is building. You want to be in the room where it happens. Next week, we have Youth Voices Navigating Behavioral Health Crisis with Kelly Davis and some of our youth leaders. 2 weeks out, we have debate number 11. We're finally there. Should mobile crisis teams respond in pairs with Megan Gleason and Dr. Ken Minkoff? And in 3 weeks, we have a fireside chat on suicide treatment with Dr. David Jobs. 4 weeks out, we're talking about emergency commitment with Representative Steve Elison and Judge Steve Leifman. Thank you so much for being part of this powerful jam today. Thanks for watching. Be sure to tune in, log on, join the movement, and we will see you next week.